Welcoming our speaker for today, Dr. Melissa Erickson. Dr. Erickson graduated from the University of Cincinnati College of Medicine in 2003, and then completed her family medicine residency at St. Vincent Hospital in Indianapolis in 2006. She has spent most of her career as a primary care physician, with the last 5 years at UC's Health Florence location. Several years ago, she developed a special interest in cancer survivorship and joined the survivorship team at UC Cancer Center 2 years ago. She sees patients for survivorship visits and also serves as the medical director of the Cancer Survivorship Program. A year and a half ago, she also joined the survivorship team at Cincinnati Children's Medical Center, seeing adults 25 years and older with a history of childhood cancer in their long-term survivorship clinic. This past November, she established the first oncology primary care clinic in the region at the Barrett Cancer Center. Melissa is excited to be talking about the important role that primary care physicians play in high quality cancer survivorship care. Welcome.
Thank you so much for that introduction. So today I'm going to be talking about COVID-19 and cancer. And I will be the first to say we still have many questions about this topic. I'll do my best to help highlight what we do know and what are some of the most current guidelines and recommendations. All right, so I wanted to start by just kind of reviewing what are the numbers to date. In the United States, we've kind of had a staggering, 48 million cases and a little over 780,000 deaths. When we look at the percent of people who are eligible for vaccines, so right now that's ages 5 and up, who've received at least one vaccination, it's 75%. Those that are fully vaccinated, 5 and up, are 63.4%. And those that have had a booster dose is around 23%. This is a graphic I'm sure many of you are familiar with that has sort of charted the course of the cases of the daily cases of COVID since the start of the pandemic. And you can see clearly the different spikes. A year ago is when we were sort of in the worst of things. This past summer, it seemed like things were improving, and then Delta hit with this spike right here. And now, I feel like evolving on a daily basis. So I thought I would just put up front what's probably front and foremost in many people's minds, at least it is mine, with the Omicron variant of COVID. What do we know? What does this mean? First, it's very new. It's only been recognized, I want to say about 2 weeks now, was first found in Botswana and South Africa. And just this past Monday, the World Health Organization declared global risks from this variant as very high. Cases have been identified in at least 20 countries. And again, this information is evolving rapidly. Just today, I had to update this from yesterday. It's here in the United States. We've had 3 cases, one in California, one in Colorado. Both of those cases had recent trips to South Africa. They had been vaccinated, but had not yet received their booster. And then there's a case in Minnesota that's the first known community transmission case in this country. I was unable to find the vaccination status of that individual. So why are scientists concerned? Why all the buzz about this? Well, on paper, it looks like it could be worrisome. There's a lot of new mutations. There's something like 30 mutations. And it's the location of these mutations that's concerning. It's on the spike protein, right? And that's a pivotal place that allows the virus to enter our cells. It's the target for how our vaccines help our bodies produce antibodies. So they're worried that there could be, there's 3 variables we look at. How easily is it transmitted? Does it cause more severe disease? And will the vaccine work against it, right? Those three questions, we don't have the answers for that yet. It's probably going to take at least 2 weeks before we kind of get some answers. You know, they were able, it was pretty amazing. The scientists in South Africa were able to genotype the variant pretty quickly to kind of get the sequence for it. And then that was distributed. And now scientists are working to put together sort of a viable model to test, is this, you know, is it effective against the vaccine? Or I mean, is the vaccine effective against the Omicron variant, et cetera? So the question is, what can you do now to protect yourself? I wish I had great new answers. Unfortunately, I don't. I think one thing to stress is, you know, wear your mask if you're indoor in public spaces, right? When you don't know the vaccine status of individuals, I think it's a good idea to wear a mask. I'm probably preaching to the choir with many of you here participating tonight, but I think it's an important reminder. Good hand washing, social distancing, and one of the most important things, if not the most important thing, is just getting vaccinated. And we're going to talk a little bit more about that in detail at the end of the talk. All right, well, what about, so that's kind of catching us up to date a little bit on COVID, but what about COVID and cancer? We know that having a cancer diagnosis is both a risk factor for COVID and negative outcomes. What are some other risk factors that play into this in cancer patients? Those who are older, those who have comorbidity. So if you have underlying diabetes or high blood pressure or lung disease, for example, that's going to increase your risk. If you're currently receiving chemotherapy, if you have certain types of cancers, particularly, and we'll talk a little bit more about this in detail, lung cancers and hematologic or blood cancers have been shown to be higher risk. And those that have completed therapy in the last 5 years. All right, so I'm going to share a couple of studies that I think have some important information. There was a consortium that was created called the COVID-19 and Cancer Consortium at the beginning of the pandemic. And this is a multi-site consortium that includes UC. Dr. Weiss Draper is a head and neck oncologist who was one of the authors of this paper that was published this past March. And what they did was they looked at a group of patients that had cancer and a diagnosis of COVID to kind of look at this, you know, look at the clinical factors. Were there things that made them higher risk? How severe was it? And so they looked at almost 5,000 patients who were diagnosed with COVID between the time period of March of 2020 and November of 2020. And these folks either had active cancer or just maybe a history of cancer. Of this group, 58% were hospitalized for COVID, 14% unfortunately died, and 61% had cancer that was present, diagnosed, or treated within the year prior to diagnosis of COVID. What were some of the characteristics that led to a higher severity of COVID? Again, these are similar to what I mentioned previously: older age, male sex, obesity, having underlying conditions like kidney disease, heart or lung issues, diabetes, if they were Black or Hispanic ethnicity, if they had recent cytotoxic chemotherapy, or if they had a blood cancer. Patients who were diagnosed early in the pandemic did worse. And I think that's probably not shocking, right? I think we were sort of building the plane as we were flying it, right? And I think, you know, providers got better at how do we treat this. They found that certain anti-cancer therapies had worse outcomes, had worse mortality rates in those first 30 days after diagnosis. All right, the next study I'm going to talk about was a study published this past July that came out of Wuhan, China. And what I like about this study is they have 3 different groups to kind of help tease out what is COVID, what is cancer. So this first box here, this green box, these are patients that had both COVID and cancer, and there's about 166 patients. The second group just had COVID, so no cancer, just COVID, and about almost 500 patients. Then the aqua group here had no COVID, just cancer, and about 500. So group 1, COVID plus cancer. Group 2, COVID only, group 3 cancer only. And they looked at some different variables. And this was, again, getting longer term data is challenging when we've only been living in this pandemic for a while. So this is actually looking at 1 year, 1 year mortality rates from the time of diagnosis. And so an all-cause mortality rate, that just means they passed away, but could be from anything, right? So they broke that down by these 3 different groups, right? So the green group, the COVID plus cancer, 30% passed away in that first year, compared to 9% that only had COVID, 16% that only had cancer. They looked at hospital mortality rates, so passing away while in the hospital for COVID. 20% with COVID and cancer, 8% COVID only, 2% for cancer only. The good news is that if patients managed to survive their COVID infections and went home after the hospital, their long-term mortality appears to be similar to cancer patients only. You can see here 8% versus 0.4% with COVID only and 15% with cancer only. Additionally, long-term sequelae, right? We know that there are some long haulers, right, who are developing chronic lung, heart, or neurologic issues, just to name a few. It did not seem like the cancer patients had higher risks of these issues. They also wanted to break it down by subtype, right? Did certain types of cancers have higher mortality rates? Again, these hematologic malignancies or blood cancers continually show to have sort of the highest mortality rates, followed by nasopharyngeal, brain, and skin, digestive system cancers, and lung cancers. Lower rates were seen in genitourinary, female genital, breast, and thyroid. All right, I'm going to shift gears a little bit now and talk about what effect did this have on cancer screenings and what long-term effects does that mean? So we know early in the pandemic, everything shut down, right? It was something that we sort of employed to really minimize the risk of in-person visits. And while that was necessary in the beginning, unfortunately, it led to a significant decline in cancer screenings, delayed cancer diagnoses because of that. Unfortunately, some suboptimal care for people that had cancer during this time period, and a predicted negative impact on cancer mortality, which we'll talk about here in a minute. So there was a study with 11 million people, and it looked at screening rates for a couple of common cancers: breast, lung, cervical, and colon. And they looked at the rates in April and May, so the first 2 months or first beginning months of the pandemic, compared to a similar time period the year before. And it showed that there was a drop in 62 to 95% in the screening rates for these cancers. Over the rest of the year of 2020, so June and onward, the rates increased, but they never returned to the previous levels. So they've done some modeling to see what kind of effect is this going to have, these sort of delayed screenings. And it's thought that when we look at, for example, breast and colon cancer, over the next decade, there may be an excess of 10,000 deaths, which is sort of a 1% increase, which is really, really disheartening. So what's the path forward in terms of how do we handle screenings? I think first and foremost, and these are some recommendations that were published recently, we really, as primary care physicians especially, need to prioritize screening for those who've never been screened or those who are really overdue. What's the group that was sort of hit the hardest by the pandemic? Blacks, Latinos, Native Americans, those with minimum wage employment, those that haven't had insurance, really have faced more challenges. And we know that these are the very populations that already had worse cancer outcomes before the pandemic. So it's kind of like faced with a double whammy there. Many survivors, I think it's gotten better with time, but especially in the beginning, they were afraid to come into healthcare settings. I remember My mammogram was delayed, and when I eventually went in to get it, I mean, I knew it, I did it, and I was fine, but I was admittedly a little bit nervous, right? So we just want to make sure we're educating and talking with our patients, saying, look, it's really important that if you develop new signs, let us know, right? Don't sit at home and be worried to not have it looked at. We have obviously used some telehealth during the pandemic, but even that's not a perfect system. You know, there's a lot of potential barriers with that. But the take-home message, if it's required, in-person physical exams shouldn't be avoided. It's always better to come in and have us take a look at it. Things that we could consider, you know, are there screening methods that don't require in-person visits? For example, Cologuard for colon cancer. No one would say that this is superior to colonoscopy, but is it superior to doing nothing? Yes, absolutely. And we can do a good job. You know, primary care physicians have been tasked with saying, hey, even if they're there for a problem visit, let's talk about some of the screening so that we're, you know, not making them come in for multiple in-person visits. What about mental health? I mean, my goodness, we know that the mental health needs during the pandemic among the general population has just skyrocketed, right? Cancer survivors, we know already faced higher rates of things like depression, anxiety, and distress. But this was made worse by, you know, there might have been interruptions to your care if you were getting treatment at the time. Many of my patients had to go to their cancer treatments alone, whether that was surgery or chemo, when visitors weren't allowed. There's the worry about increased susceptibility, as you know, we've kind of already talked about previously. And something more recently that I feel like, unfortunately, I've been seeing a lot more is my cancer patients who are not only having to navigate cancer and COVID, but also the grief of losing loved ones due to COVID. And I think that's an important thing that we need to kind of think about doing a better job of addressing. And so I think we as healthcare providers need to do a good job of screening our patients for this, talking about it, validating feelings, right? That it can be normal to kind of feel like this, and just making sure that we get them to the appropriate mental health services. You know, a quick word, lifestyle matters, right? You know, now more than ever when we are stressed, but it's certainly not uncommon that I have seen, you know, gyms shut down and patients stop being as physically active, and they were inside more, and they started eating more or less healthy than they used to. A lot of patients have put on weight during this time period. And so it's just a reminder that this is a good time to really focus on things that you can control, right? Being more physically active, focusing on healthy eating, making sure you're getting a good night's sleep. For example, you know, UC, and I put a link here, UC offers a lot of yoga, Tai Chi, mindfulness, music therapy, exercise classes, and certainly Cancer Support Community offers a whole host of these as well. So these are important things that you can do to kind of keep yourself as healthy as possible. All right, finally, we're going to shift gears to talk a little bit about the vaccine. So both the CDC and the NCCN. So the NCCN is the National Comprehensive Cancer Network, and it's sort of like the Bible for cancer care. It's what oncologists really use to help guide treatments and that type of thing. And they do recommend that all cancer patients should be vaccinated against COVID. This is included that during active treatment. The one exception is that if you have had a stem cell transplant or CAR T therapy, the recommendation is to wait 3 months after that before you get it. A quick plug for the flu shot, it's okay to give at the same time as the flu vaccine, or if you get them at different time periods, there's no minimum interval. So an important question is, how effective is a vaccine in cancer patients? You know, in the initial vaccine trials, cancer patients were excluded, so we didn't really know. And we were kind of basing it more on expert opinion / our experience with flu shots in terms of would it be safe? Would it be effective? Since then, though, we have had some newer studies that have come out trying to help answer that question. Unfortunately, we have found that the vaccines may not stimulate effective immune responses in some people with certain types of cancers, largely blood cancers. We know that patients that have these types of cancers, as part of the cancer, they have a dysfunctional immune system. And so their body's not able to mount the same type of response that others might. So a couple of studies, and I included this picture of Colin Powell because you probably heard, he passed away, he had COVID. I believe he had been vaccinated, did not have yet his booster, was scheduled to, but hadn't had it. And, but had underlying multiple myeloma, right? And so this one study in the United States found that 46% of patients with blood cancer, so examples, B-cell, CLL, lymphomas, multiple myeloma, did not produce detectable antibodies after 2 doses of the Pfizer vaccine. Another study kind of showed some similar things. This was published this past April. It looked at antibody production, virus neutralizing ability, and T-cell responses in people with and without cancer. And they found that after 1 dose, those with cancer had a much weaker immune response. If they had 2 doses, it actually was pretty comparable to patients that did not have cancer. But this was for patients with solid tumors, right? So for example, breast or colon or lung. This particular study wasn't large enough to reach conclusions about the effect of a 2nd dose in blood cancers. But probably the largest study to date looking specifically at blood cancers is a study currently, it's an ongoing study being done by the Leukemia and Lymphoma Society that's looking at vaccine responses. They found that about 1 in 4 patients that have blood cancers did not produce detectable antibodies after either the Moderna or the Pfizer vaccine. And I think this really stresses the importance of, vaccinating those around them, right? So when you get vaccinated, you're not only protecting yourself, but you're protecting those that might not be able to mount an adequate response. Now, on the flip side, well, that sounds a little bit depressing. On the flip side, 75% of patients with blood cancer will mount adequate antibody responses. This is a little infographic that if you have a specific interest in they did a breakdown of the different types of blood cancers. So things like multiple myeloma, chronic myeloid leukemia, Hodgkin's, those are pretty good antibody response rates. It drops when we start to talk about non-Hodgkin's lymphoma, large B-cell lymphoma, and certainly the one with the least was sort of mantle cell lymphoma. They also took a look at treatment regimens. Some of these treatment regimens, such as rituximab, which is one of the more common of this list, we know that those target B cells, and B cells are needed to develop antibodies. So it's not totally surprising that some of the patients on these treatments did not mount good antibody responses. So what about a 3rd dose, right? What does that do? What effect does that have? We found that a 3rd dose response among patients who had no detectable antibodies after their first 2 doses actually looked pretty darn good. 55% of those patients made detectable antibodies after the 3rd dose. So I think it really drives home the importance of that 3rd dose. So let's review quickly, because I know I get confused even because it changes so quickly about what are the current recommendations for vaccines. All right, so what if you're immunosuppressed? And we'll talk about, actually, let's just jump to that and then we'll come back. What does immunosuppressed even mean, right? So it means you have active cancer treatments, you have had an organ transplant and are taking medicines to suppress your immune system, you received a stem cell transplant within the last 2 years, you have a primary immunodeficiency, such as those listed, you have advanced or untreated HIV, or you're on high-dose steroids or other drugs that might suppress your immune system. All right, so this applies to this chunk of people here. So it's a little bit different than just saying get a booster, right? So if you're immunocompromised and you're at least 5 years and older, you should get a primary series as soon as possible. If you had Moderna, you should get the primary series, which is two vaccines, and then get an additional 3rd dose 28 days later. Same for Pfizer. If you received, if you're immunocompromised and you already received the primary series and that third dose, you are still eligible to receive a booster shot. So that would be dose 4. And we'll talk about when that booster is given. If you had J&J, you should not receive an additional primary dose, right? That was just a 1-dose series. However, you should get a booster shot at least 2 months after your initial J&J. All right, so what about everybody else? If you're not immunocompromised, what should you do? The answer is kind of easy, get a booster. Initially it was, well, we just rolled it out with higher risk folks, but now we're really saying 18 and up, you should just get it. So again, on the left, it says if you've had Pfizer or Moderna, you should get a booster 6 months after you completed your second dose. If you've had J&J, you should get it 2 months after you completed your initial dose. Their mixing and matching is okay. They've had some studies looking at that. In fact, I've had some patients who've had J&J who said they've elected to get a Moderna or a Pfizer booster just because it's perhaps shown a little bit more robust antibody production, but all of them are acceptable as a booster. And this is, for any of you who might be listening who do have a blood cancer, there's a registry, right, through the Leukemia and Lymphoma Society that's still enrolling patients to kind of help study the effects of COVID on cancer, on vaccine efficacy. I have a patient currently enrolled in this, and he's, it's not a lot of extra work. It's a few extra blood draws and some testing after he gets vaccines, but I think it's really important information that we can glean. So with that, I will end. That's the last of my